Hello everyone, I'm delighted to welcome you all this evening. The time is 6 p.m. and today is 19th of May. This will be our third POCUS webinar. I'm Dr. Priyadarshini Marathe. I'm the POCUS lead at the Oxford Emergency Department. Today we've got a spectacular lineup for you. We will start with the basics, a review of the Blue Protocol by Daniel Lichtenstein, followed by 5 fantastic lung ultrasound cases. Let's begin. Karim, do you want to begin?
Thanks, Priya. Hi, everyone. So I thought we would kickstart the session today by just reviewing one of the seminal papers about lung ultrasound. And so the paper that we're going to talk about, and we'll just leave it in the Microsoft Teams to have a look at it later if you want, is this paper here, published in Chest in 2008. And it's titled Relevance of Lung Ultrasound in the Diagnosis of Acute Respiratory Failure, the Blue Protocol. And Blue stands for Bedside Lung Ultrasound in Emergency. And it's written and carried out by these two guys, Daniel Lichtenstein and Gilbert Armézier, two French intensivists who gathered the evidence and produced a very robust protocol with quite high accuracy, which can be used by fairly novice sonographers to come to an accurate diagnosis. So that's the paper, and we're just going to run through it and let's see what the evidence is presented in this paper. So the Blue Protocol, the bedside lung ultrasound emergency, it was carried out over approximately 4 years, where in 2 intensive care units, 2 physicians would see patients as they came in with acute respiratory failure into the intensive care unit, and they would carry out a sonographic assessment of the lungs only, plus or minus a peripheral DVT assessment if needed. And they do that all within 3 minutes. It's a very So they came in, did the scan, and then the results of the scan was not open, it was not available, it was basically blinded to the people who were looking after patients, and they weren't involved in the care at all. And what they did is they collected this data and then they compared it to the final diagnosis when the patient was discharged, and the final diagnosis was achieved without ultrasound, so by clinical acumen, bloods, X-rays, CT, etc. So there's a few exclusions from this 300 cases. They excluded patients with very rare presentations of acute respiratory failure, fat embolisms, tracheal stenosis, or a massive pleural effusion, which wasn't really a diagnostic challenge, and fibrosis. Those without one single diagnosis, so those with no final diagnosis were excluded, and those with several official kind of equally important diagnoses were not excluded for the purpose of this protocol. So at the end of the 4 years, 260 patients were included. And essentially, what they came out is this is the protocol that they recommended, and it's a very simple step-by-step protocol. And I appreciate there's quite a little bit of it here when you first look at it. But once you understand lung ultrasound, it really is very straightforward. And the first thing they suggested was, is there lung sliding? And we'll learn a little bit more about lung sliding later today in one of the cases. And that essentially is the first step that you want to look at when you're conducting the Blue Protocol. And if it's abolished, then the first thing you think of is, well, is it pneumothorax? So it depends on what else you see. So if you have an A prime profile, so basically A lines without lung sliding, and you find the lung point, so a site where you can see lung sliding as the lung touches, as the pleura comes into contact with the chest wall, that then with almost 100% certainty is very specific for a pneumothorax. But if you cannot find it, then you need to consider other diagnostic modalities to fully include a pneumothorax. So it's very sensitive. If you don't have lung sliding, it's very sensitive to pneumothorax, but it's only until you find the lung lung point that you can say is very specific for pneumothorax. And then the other so if you do have lung sliding and you have B lines in a symmetrical fashion anteriorly, that's highly specific and sensitive to pulmonary edema. You have mainly A lines anteriorly, and then you do a venous analysis. So if they did basically DVT scanning of the lower limbs, only using compression testing, so they didn't use Doppler, so something that we teach in FAMOUS and CUSIC. And if they found thrombosed veins, that was likely to represent P as the cause of respiratory failure. If the veins weren't thrombosed, then they looked at the sides of the lungs, and there, if they had a posterolateral alveolar or pleural syndrome, basically consolidation of fluids, likely to be pneumonia, not likely to be COPD or asthma. So essentially, clear lungs in respiratory failure without any evidence of basally of effusion or consolidation is likely to be an obstructive picture. And then the final part of this was if you see this A, B, or C profile. A, B profile means asymmetrical B lines, or the C profile, which means you basically see consolidation anteriorly, is very specific for pneumonia. So that's the kind of the blue protocol in a nutshell. And the numbers that they ran through this blue protocol to achieve that are shown here. And essentially, without going into too much detail, each one of them was very sensitive and specific for the diagnosis they came to once they compared them to the final diagnosis. And they come up with a combined diagnostic accuracy of 90.5%. So 90.5% of the patients that they saw and gave a diagnosis there and then within the first 20 minutes of their admission, within a 3-minute scan, at the end of the scan, sorry, at the end of their time in ICU, matched up. So that's kind of what the strengths are really highlighted there of the blue protocol and the evidence that they were able to present. Now there are some caveats to it. I think it would not be fair if we didn't look at them. And one of them is that they did exclude patients who had more than one kind of top diagnosis. And we know that in reality, often pathologies do coexist. So that's one thing to bear in mind. Also, if 90.5% were right, that does leave a room for doubt. So something that you must keep in mind that as any good clinician does when they're using a test is to maintain a healthy amount of skepticism and make sure that it ties up with the rest of the clinical findings. The accuracy was high, although it was in the hands of two very experienced clinicians. So it's fair to say that when you're starting off, the accuracy of what you come up with as a diagnosis at the end may not be as high, and hence why you should be supervised until you're experienced enough. And obviously, from a study point of view, they weren't blinded. They could see a patient, and often you can diagnose the patient by just looking at them, which I don't think necessarily is a bad thing. We obviously advocate ultrasound to be used in conjunction with the rest of the clinical picture, and actually that's really the key to making it useful and making it reliable. So in summary, the paper showed that performing lung ultrasound plus venous analysis using the blue protocol can rapidly help establish diagnosis in the patient presenting with acute respiratory failure. And the key part of that you're advocating for is that you can start the right treatment early, which is a huge benefit to the patient, not just from a survival point of view, but also patients who are in respiratory distress. It's a very frightening and difficult time for them, and you can help alleviate those symptoms quicker. Using it in conjunction with the rest of the clinical context is likely to make your diagnostic actually even better, reduce error. And finally, remember, when your patient is blue, probably perform a blue protocol. Thank you very much. Any questions?
Thanks, Karim. That was excellent. So when your patient is blue, promptly perform the blue protocol. Excellent. We can have a couple of questions now, if anyone has any about the blue protocol. Please feel free to ask them if you think of something when we're discussing cases, and hopefully the cases that we discussed today can help you, understand the pathway and the protocol a little bit more.
Can I ask Karen about
yeah,
from a kind of a learner's perspective? So you have this algorithm that you presented, and the logic's clear. Then you've got to find a way to kind of make that in your own head and make it intuitive, like how we learn hard examination, chest examination, going through the routines. How long do you think it took you to kind of feel that's embedded in your head as the way, if that's what you follow when you approach the unwell patient? Do you want to give a sense of you go from picking up the paper to feeling like it, your own intuitive, rapid approach is guided by that?
So was that how long did it take me to integrate that?
Yeah, and how easy you found that whole process?
I think when I started doing lung ultrasound, it's probably within a month of using it regularly, it became quite natural to me. So probably using it 2 or 3 times a week, actually not that much, but actually over the month's time became quite intuitive. And I think the key thing, the blue protocol to me, I don't follow the blue protocol exactly, but the key thing is actually paying attention anteriorly to what happens is very important, as it helps establish the diagnosis quickly, whereas they save the posterolateral aspects towards the end, which requires a little bit more interpretation, because the bases can become diseased quickly in anyone who lays supine for a long time, and it can become soggy with infection. So basically it took me like a month basically to be very comfortable with it, and that's not really using it that intensely. And just also the key thing is pay attention to anteriorly what you're seeing rather than just posteriorly. Priya, I think you're muted.
Oh, sorry. I'm sorry. So we have a question, and in my experience, no one uses the actual blue or PLAPS points and just scans the lung thoroughly. Does anyone feel this is more or less accurate, say, compared to mowing the lawn approach? I think Karim, you answered that.
I think I personally don't do. This patient was the patients who they looked at were in acute respiratory failure. They're very unwell.
Yes.
And when you're that unwell, you're almost certainly able to establish diagnosis quite quickly just from 3 points, and that's my experience with it. In patients who aren't so unwell, where things are a bit more subtle, they tend to have so much pathology, and you do have to comb to find your diagnosis, and especially looking for something like the lung point, you really have to do the lawnmower approach until you find it. So I think it's actually depends on the clinical picture and how unwell your patient is and how readily you'll find what you need.
True. If there are any other questions, maybe Dan can present. I think Dan had some beautiful images and videos he got from a patient he saw outside of the hospital. Dan, do you want to tell us more?
Can you see my screen?
Yes. Okay.
All right. So thank you, Danny. My name is Dan Lasserson. I work on AAU, and we just started to give some medical input to the acute hospital at home teams. This is a very strong nurse-led service that I think was probably, in my view, crying out for some medical input. I would say that, wouldn't I? And I thought this was a great opportunity to try and deliver more of the acute diagnosis in the home and care home setting, and say, could we actually use that as our kind of scaffold to deliver a broader and wider scope of treatment within the hospital at home framework. And this was the first case that I saw. So I was previously working in Birmingham. I'll come back to work in Oxford, where I used to work previously. And this was the very first case when we opened our doors to the hospital at home service in care homes. So I thought I'd better take us through it, because I think it's quite interesting and has some useful learning points to me, certainly around how we use POCUS for decision making. So your call comes in. This is the first day of running a new service. You're not sure what to expect, and you're just one doc alone, but you've got an absolutely weapons grade group of nurses working with you. So this lady's 94. She lives in a nursing care home, also has residential beds. You know, she's got dementia. She has heart failure with ejection fraction last measured a year ago of 25%, and she's under the heart failure team regularly. She had a previous aortic valve repair for stenosis sometime back in the past. All you know is she's been increasingly sleepy over the last few days. She was previously swabbed in the care home about a couple of weeks ago and is positive for SARS-CoV-2 PCR. She was found very sleepy and hypotensive this morning, BP 77042, and the nursing home called the GP, and the GP called the admission avoidance team, which is part of our acute hospital at home service. And his question was, can you just go and prescribe some fluids? And that was what the GP wanted. And all he said was that the family would prefer to manage the care as possible. So that's our case. So you turn up, and there's a lot of new things about, you're used to walking into resus or walking into a medical ward or walking into ambulatory care or medicine. Walking into a care is quite a different business. So you turn up, and the patient is sitting kind of propped up in a chair like that by the dining table. There's a full plate of food. She's not eating. You walk towards her. She's not really fixing gaze on you, not really responding, but she's not agitated either. So you get a wheelchair. You personally wheel her back to her room. You're told where it is. And the nurses with you help you transfer her to get into a high back armchair. You get some obs. So saturating normally, temp's okay. Pulse 62, blood pressure is a little bit higher, but it's probably still not ideal, although maybe okay for someone with heart failure, and resps are up a bit. So the first thing we do see in the armchair is lung ultrasound, and these are her images I acquired with my Butterfly IQ, with her sitting in her high back chair in her room in the care home. So here we have, this was taken from the left axilla, and you see a very irregular pleural line here, suggesting there may be some subpleural darkness here, but these B lines, as you'll see, are these lines that are coming from the pleura all the way down the length of the field, and those are B lines, and that's an interstitial syndrome. There's fluid in the lung interstitium, and combined with this very irregular looking pleura, this is, you know, what we really recognise to be due to COVID itself, with a nice subpleural dip there. We've got lung sliding, so obviously, well, we definitely know there's a pneumothorax because we've got all these B lines in activity here. So you know you're looking at a lung that's adherent to the pleura, and there's signs of COVID change within it. And here we go. Here's another one. Again, we've got some A lines here. These are the sort of harmonics, if you like, that the artifact produced in normal lung, and the B lines cutting across them and obliterating them, and a couple of B lines here coalescing to be quite bright lines down on this side, on there, and sliding too. So already you're getting a sense of, you can see COVID change in the lung, and obviously you know she's PCR positive, but clearly you've got the impact of the virus on the lung. However, you know that her stats are normal. So we have an iStat with us as well, so we can take blood tests too, because we want to have that multi-dimensional assessment of having all the point of care diagnostics, both imaging and bloods. How much of the hospital can we replace within the care home? And hopefully you've got the helpful surprise of electrolytes are okay, but very, very high urea and creatinine. And we also have, and this on the iStat Chem8, her glucose was fine. We know she's diabetic. And she's acidotic on the CG4, and her lactate was 0.7 at this stage. So pH 7.23, acidotic, basic excess -11, acidotic, bicarb low. So she's buffering that acid, but still with a very acid pH. Because we've got these iPads that let us know what else goes on, we know that 18 months ago was her last blood test on the JR system, and her creatinine was 118. So the iStat creatinine is slightly higher than the lab creatinine, but basically you can be pretty confident at that level that you're dealing with someone that's probably got AKI3 in terms of the numbers. So because you know that she's got renal impairment, actually we have our Butterfly IQ, we could just flip it into abdomen mode, go down below the lung and have a look at the kidneys. So for reference, I've nobbled this from Wikipedia. This is reference for hydronephrosis. This is a longitudinal view through a kidney on ultrasound, and you've got all this urine really building up, squeezing that pelvis, and so the cortex and medulla is all squeezed together. So that white is really, and that's normally quite juicy in here, that white of the medulla, and the cortex is dark around it. So that's what you're looking for if there's hydronephrosis. So this is me scanning in the longitudinal plane, again with her just sitting forward in her high back chair in her room. And here we have the renal pelvis, so it's white in the middle, it's not being pushed back sort of here. So this is actually a normal kidney in longitudinal view, and that's a liver there. This is a right kidney. So you're pretty, at the end, the left one looks the same as well. So we're pretty happy, I'll just show it again, as we fan through the kidney, that this isn't a surgical cause. I mean, you could argue that if you're 94 with all those comorbidities, if you found it, what would you do? Well, we could prognosticate and we could talk more with family. So it's useful to know we're probably dealing with medical causes rather than an obstruction. You know she's got heart failure. So actually we want to say, what is this ventricle doing? And this is the challenge I find I'm finding, okay, I've got one case here. This is the challenge I think is actually about positioning patients, because you've got a care home bed where they lie flat, you've got a high back chair where they're propped up, but you don't have this hospital bed where you can adjust and get optimal images. And Helen and I have had some interesting back and forth WhatsApp chat about what's a definitive image or the concluant image of the Canadian thing. So I'm sure if I presented these images in Canada, I'd be banished to the far north, the waste of the Arctic tundra, for daring to present these images to the strict Canadians. But nevertheless, we're pragmatic, and in the care home, we're trying to get all the information we can from management. So this is a short axis view where you're kind of cutting across the left ventricle. And again, she's sort of sitting forward. I'm trying to get a position where I can see some papillary muscles on the left side. There's a bit of movement. She's not that happy with it, but we're saying, well, actually, we can see that the left ventricle is there. We don't have much septal movement. It's not the best picture in the world. I definitely grant you that. I took some more images as well in our slightly different views of this, so you can get a better picture. But there is some contraction. It's not perfect. However, I realize that the go-to view really in this care setting is the subcostal view, because the patient's lying flat for the ideal one, and you can definitely get people lying flat in a care home. So this is my subcostal view. This is liver. I don't know if you can see my cursor or not, but this is the liver on top. The liver is your friend in the subcostal. It's a great window in which you can see the heart. And we've got right ventricle, right atrium, left ventricle, left atrium, and almost a little bit of the aortic root there as well. So this is the left ventricle, but this is a great place to do pericardial effusions. When you've got a high urea, pericardial effusions can be quite common, so it's quite useful to make sure that's what you're dealing with. And also when you've got someone who's got, is very hypotensive, we'll make sure you're not missing an effusion that's compressing left and right ventricular function. That's certainly not the case there. But from our subcostal view, of course, we can just turn our probe slightly and we can see the inferior vena cava. And one of the big questions in heart failure AKI really is this heart failure because this patient's dry, in which case they need fluid, or have they got heart failure because they've got poor ejection fraction, unable to move blood through the kidney, and are they in fact overloaded, in which case your diuretics may be better because you may end up pushing diuretics to improve things. So getting that assessment of wet or dry is key. And this is an inferior vena cava. I want you to look at this top of the IVC here as it goes into the right atrium, and you'll see the impact that respiration has on the diameter of the inferior vena cava. So as you can see, as she breathes in with respiration, the IVC becomes almost occluded. So she's so centrally dry, and of course the urea is clearly our big giveaway here, that actually there's plenty of room in this circulatory system for some IV fluid. And this may well be, so this is someone in whom actually we're clearly going to push fluid, not diuretics, as are what we do with heart failure AKI. So there we go. So I find this actually is quite a helpful view, and you can pretty much reliably get it, as I'm finding in the care home setting, because all patients can lie flat by and large, and there's no problem really in acquiring this one. But trying to get nice, clean pictures in the right, with the right sort of body in the right position for the other cardiac views is more difficult. Okay. So then you look at a drug list, and this reads like a who-who of what not to prescribe in AKI. So we've got candesartan, spironolactone, frusemide, atorvastatin, temazepam, no wonder she's sleepy, metformin, she's acidotic, and meprazole and paracetamol. So at least we've got plenty of targets of we can apply our drug chart scalpel and try and help out. And a long discussion with the daughters. Look, they just don't want it in an acute hospital. And the clear message was, do whatever you can to support care within the care home. So with that strong steer from her daughters, that's what we did. So clearly we took a massive scalpel to her drug chart in the care home. We delivered intravenous fluid daily with hospital at home and nursing visits, more gently than we would have done on the hospital ward for sure, but actually you're dealing with a ventricle that doesn't work very well, so maybe a slow drift back to normality is better than trying to rapidly replace. And by day 40, urea had halved, creatinine come down to 187, and much brighter in herself. In fact, my abiding memory of her is she told me off for stopping her temazepam and said she's got a terrible night's sleep, and it was that horrible doctor in the hospital who came and stopped her temazepam. And this is somebody who wasn't 4 days, who 4 days wasn't touching any food at all, was now sitting in a chair, pouring herself drinks from a drug on the table next to her and saying she's thirsty and wants to drink. So we stopped the fluid at that point. So this is only case number one, but we hope it's one of many, and we can reflect on how this helped. But certainly for me, I felt much more comfortable managing what could be a very complex medical situation of pretty severe sharp AKI with clinical impact in somebody with a pretty low ejection fraction who is so fragile, they need to be under a hospital at home a heart failure team. A nice example of how a pluripotential view on POCUS, there are a number of organs you want to be doing in a sweep if you're managing care in this setting. And we sort of look forward to trying to develop and evolve this model and see how we can make this much more of a frontline offering in the acute care pathway for patients when they ask for help, whether it's via paramedics, GP, or even patients who come to ED and you want to send them home with a SWAT team descending. So I'll probably stop there let you guys.
Thank you, Dan. Thank you. That was great. This is another excellent example of how ultrasound is no more just an investigation that someone else has to do. It is point of care. It is at the tip of your fingers, and you are making decisions. Not like you said in the beginning. Not resus, not ambulatory care, in the patient's own bed, which is excellent. Excellent. Great. We've got another case now, if it's okay. Can I please ask Helen to present?
Yes, absolutely. Perfect. I just unmuted myself. That's great. Yes, absolutely. So I'll present another case, another interesting one. Okay, can you see my screen? Probably you'll see yourself now. So just a second. Sorry. Okay. Okay. Great. Can you see my screen?
Not yet.
Not yet.
Not yet. Okay. What can you see?
You.
Oops. Okay. But then I said, sorry. But then now I cannot see myself anymore. I can just see my screen. Wait. Sorry about that. Oh, sorry. I need to select which one I want to. Sorry, it's only my second time on the.
Yeah, perfect.
Perfect. You see it? Okay, sorry, it's only my second time on Teams. So perfect. So welcome to this little presentation. So another case today about a clinical case where ultrasound has been more than useful. So another one quite different from the ones I presented last week. Basically, because I presented a couple of them, multiple ones. But this one involved a postpartum situation. So you have a 35-year-old female. I was at the JR, and she presented herself with the 9 days. So she's 9 days postpartum. She just delivered a really lovely baby, and she's complaining of shortness of breath, cough, and fever. She has no past medical history. She never smoked in her life. She is a G2, P2, so she delivered her second baby. She is actually breastfeeding. She had a non-complicated vaginal delivery at home 9 days ago with a midwife. And of course, after that, they have to go to the JR to do the newborn physical examination. She said she stayed at the JR for about 12 hours. So she's been in contact with the midwife and some healthcare professionals. So she says that for the past 2 days, she is progressively short of breath. She's coughing more and more, and she has fever. It all got worse today with some dizziness. She hasn't lost conscious, okay? She complains of chest heaviness, but no clear pleuritic chest pain. She denies any other symptoms. The calves are normal. She doesn't say that she's swollen, and her low-she's are normal postpartum. She's mainly worried about COVID, of course, and or having a mastitis because she's worried about her breastfeeding, and of course the consequences on her baby. So, what did she look like? So her respiratory rate was quite raised, okay, 30. She was febrile, 39 degrees. Heart rate a little bit elevated, well, 104, okay. Saturating well, 96 on room air, with a good blood pressure. She's oriented. She looks unwell, but not toxic. You know, she just like she looks a bit rubbish, like really looks tired and really ill. Short of breath, she's tachypneic, you can see it, okay, no stridor, but she's able to finish her sentence. Coloration is okay, refill cap is normal, she's well perfused. The chest is quite tight bilaterally, but otherwise normal. I cannot hear any other added sounds, no wheeze, no crackles, I mean. And of course, to reassure her, I've examined her breast and there was no signs of mastitis with a good milk expression. Her abdomen was soft, non-tender, and without any guarding or any pain, nothing. Everything was normal. And her calves were soft and without any swelling. She was saturating well as well on exertion. So then what would you do? You have a young lady who is normally fit and well. She probably have some COVID symptoms, but of course the risk is higher if you keep her at the hospital. So, well, you say probably it's COVID, okay? Probably it's COVID. It was about a month ago when I saw this patient. Could it be a chest infection? Yeah. Could it be a postpartum infection? But she said clearly that she didn't have any abnormal vaginal like secretions or anything abnormal. And of course, she's breastfeeding, so you don't want to get in the way, basically, if you keep her or just a bit longer in the hospital. And by the way, baby is totally fine. He has no symptoms at all. So my plan was to discharge her as quick as possible, just to say that it's safer to be at home. But then the patient refused. And she said that she was feeling unsafe to be discharged, and she was too dizzy. She was afraid. And then she became really emotional and started to cry. And I was like, okay, well, she just delivered a baby. She had a 9 days old baby at home with another kid. I remember, I think her son was 2 years old and she was living with her husband. But then I was like, perhaps there is something she doesn't tell me. Perhaps there is something, I don't know. So then I asked all the safeguardings, like safety questions. Was she worried about any violence at home and everything? But no, it was just really because of COVID. She was really worried that she could die with her baby and everything. So I even discussed with the midwife at the MAU, and she said that she would refer her to A&E. So basically what I finally did is that I said, well, okay, let's give her some IV fluid, okay, just a bit. And then bloods were already taken at the triage. So I said, well, I wait for the blood and then we can probably reassure her and then to send her home. So then the COVID care set was done. Okay, her hemoglobin was fine. White cells a bit raised, predominance of neutrophil. Okay, sodium, potassium, creatinine, all the rest was okay. Her gas was okay as well. Lactates were like 1.5 or something. And CRP was a bit raised with really high LDH, 276. D-dimer and troponin were not yet arrived. Well, then I said, well, should I do should I X-ray her? Should I do something with her? Should I do the lung ultrasound? And then, just because she is actually breastfeeding, of course, we all know that we shouldn't use X-ray or trying to irradiate, right? Well, we should all try to do not irradiate all our fragile patients. I mean, so basically, the youngest they are, the less you want to do some X-ray, or like, of course, with some, so she was breastfeeding. So of course, her breast cells were quite like active and everything. So of course, I didn't want to irradiate her if it was not necessary to do so. So, and then here, just to show you, there's an amazing study that has been done, and it's now linked on the Royal College of Radiologists website, where you have radiation risk from medical X-ray examination as a function of the age and sex of the patient. So then here, for simple chest radiograph, okay, so a simple chest X-ray, basically, you have a lifetime cancer risk, okay, it's 1 per million, okay, inhabitant, and depending on the age at exposure. So she was 35, yeah, she was 35, so let's say she's about here, and then female is the red one. So of course she has like, I don't want to base all my decision, of course it's clinically, but I mean, of course, if you bear it in mind, of course you want to reduce any X-ray you want to do, right? So I decided to ultrasound her. So this is what I found, okay? So this is on the left lung, okay, in L3, so basically right in the axilla, where you can see, okay, here. I hope you can see my mouse. I'm showing you. So as typical for COVID, okay, you have some patchy distribution of the illness. So here you can see even some A lines, okay? So here it's quite normal, but then as you go lower, okay, here you can see some, this, let's go right now to L4 because this is basically a bit higher in the axilla and this is a bit lower basically, so it's L4. In L4 it's quite more, evident, okay, that you have some pleural thickness here. So the pleural line is quite thickened, okay? You have some subpleural consolidations here, okay? It looks like the famous chocolate chip cookie that I described in the video with some air bronchogram, okay? And you have some subpleural, effusions here. Sorry, there's a lag with my mouse, but I hope you can definitely see it. And you have some B lines that are starting from the consolidations as well. They're quite discrete in this situation, but basically you see that there is something wrong. There is some pleural abnormalities and some subpleural consolidations, right? So this was her left lung. Her right lung was a bit more less injured, let's say. So you have here at R3, so right again in the axilla, you can see some pleural thickening, and some subpleural consolidations here. And then here you have in R4, where you can see appearing from the dark, the liver, okay? I can promise you it was clearer when I took the video, but finally I've been disappointed to see the video afterward, and it's quite dark, but basically she had no pleural effusion, so you can definitely see the diaphragm without any pleural effusion above. So basically I continued with the echo, okay? So here on the video on the left, you can see the parasternal long axis view. Now she's breathing in, so of course it obstructs your view. Then she's breathing out, so then you have a better view again. You can see a good contraction, right ventricle, left ventricle here, and then you can see some really good contraction. And then I rotate the probe. Okay, on the same video, I will rotate the probe in about probably a few seconds. And then you'll be able to see, here, you'll be able to see the short axis view with the fish mouth, okay, showing that she has a really good ventricular function. And on the right video, you can see the 4-chamber view, a bit on the side, I would say. I would definitely correct the view and trying to orientate the septum a bit more vertical, but basically you can see all the 4 chambers with a really good view and with a good contractility as well, and there is no pericardial effusion. So it all looks like COVID, no? And then, like you would expect, the D-dimer arrives and it's quite raised, 2,800. But she's postpartum and troponin were normal. So basically history confirmed, just to make sure that she had no features of DVT. She was not on postpartum VT prophylaxis. And then she had a decreased mobility for the past few days, but no pleuritic chest pain. We discussed with the obstetric reg and we agreed that there was no clinical history suggestive of a PE. So then we did not do a VQ or a CTPA at the time. And finally, we have been able to discharge the patient home and with a good safety netting, of course, to come back if she had any symptoms worsen or something. And we discharged her with some TTO of Coamox because it's safe in breastfeeding, in the breastfeeding. Basically, and we've been able to rely on our POCUS findings to prescribe her the TTO. So, thank you so much.
that was a wonderful case. You, after taking the history, you clearly decided not to do the chest X-ray for the right reasons that you said.
Yep.
And let's say, I mean, I have known patients who've come in with a similar history where D-dimer was done, and without the use of POCUS, X-ray followed by CTPA also has been done, or followed by VQ, but you avoided both those tests because you could safely rely on your POCUS findings.
Yep.
That is excellent. Any comments on this case? There's a little thing on the bottom which says you want to raise your hand. You could do that and then talk or put something on the chat function. But any comments on the case? Okay, we'll wait. Helen, thank you very much. Thank you.
Pleasure.
I think we have Mridula who wants to present next. Are you here? Okay, we have a question in the meantime. Did the relatively normal ultrasound help reassure the patient?
Yes, definitely. So basically, yes, just to really well conclude this patient, after receiving just some fluid, and then she felt like really basically taken into consideration, she has seen her lungs on the ultrasound. I was showing her, I was teaching to an SHO at the same time how to do the lung ultrasound. So then she could hear me, she could listen to everything I have said. And when I showed her her heart, that was completely normal as well. She was really reassured, and I've been able to discharge her just by the time the fluid was even not finished, and I've been able to discharge her before the end. So, I mean, yes, it really reassured the patient, and I've been able to discharge her quickly.
Absolutely, that's been my experience as well. If as I'm doing the scan, and if I have the opportunity to talk through the case, it does really reassure the patient. So.
Yes.
Thanks for that case. I think she's ready with her presentation.
So can you guys see my slides okay?
Yes, we can. Yeah, if you want to go into the slideshow mode, this is fine too. If you
Can you see my slides okay? Yeah. Perfect. So oh, it looks. It is. Does that work? No, why not? It's odd.
It's the little button next to the 69% at the bottom.
Yeah,
I think that's the one.
That work?
It's quite small.
So my screen looks like a slideshow, but your screen doesn't. So I might just work through it like that.
No problem. That's fine. Yeah.
So I'm Mridula Rajwani. I'm one of the consultants in acute medicine, for those who don't know me. So contrary to the people who've presented before me, this was actually my first POCUS ultrasound. So I'm quite new to point of care ultrasound, and it just shows how great this forum is in terms of trying to get people familiar with ultrasound, and thanks for the opportunity to present. So another gratitude to Karim for supervising and actually just familiarizing me with the ultrasound machine, but also helping me get the clips onto slides for this. So this is a 29-year-old chap that we saw on the ambulatory unit who presented with. Can you see it? Can you see the slides?
We can see the slides. Yeah.
No, it's stuck on the first one. Is it stuck on the first one?
Is it stuck on the first one?
Try changing it to the second one.
I have. So I'll do it from Karim's screen. Give me a second.
Yeah, sure, thanks.
So this is a 29-year-old man who presents with a one-day history of breathlessness and sudden onset right-sided pruritic chest pain. Normally fit and well, no history of asthma, and a non-smoker. On clinical assessment, he was found to be TPE and hypoxic, as you can see there, but otherwise stable. And listening to his chest, he had some reduced air entry on the right side. His initial investigation, so bedside investigations, bloods were unremarkable, ECG looked okay, and his COVID swab came back as negative. So this is so we started off with the left side, and this was just a process of me becoming familiar with the actual images I was able to see. So on this scan, is it playing? There you go. So what you can see is you can see the rib shadows on either side with A lines and lung sliding up at the top. So this is the side that was infected, or the symptom. He was not symptomatic on this side, symptoms on the other side. And then we learned about the seashore sign by using the M mode, which is basically looking through this white line. And as the lung slides, or as there's sliding of the lungs, what you see is this haziness, so a seashore appearance of the M mode. So just remember this when you're looking, and we'll show you the right side as well. So again, on the left side, this is the lung coming in. So you can see that lung moving in quite nicely, the lung curtain moving in quite nicely. So we couldn't see any significant effusions on there. Moving on to the right side, so this looks very different to what the left side looks like. So you can see the rib shadows and you can see the A lines, but what you see is, as opposed to what was on the left side, you don't see the lung sliding up the top there. So this is on the left side. And then again, moving down a bit further on the anterior right, again you can see quite similarly that you can see the presence of A lines, but you can't see the nice lung sliding that you were able to see on that left side. And as you know, contrary to what we saw when we came down, where you saw the lung curtain come through, on the right side, we couldn't see that as beautifully, and actually the feeling was that what we were seeing on that left is just movement artifact. Now this is a complete opposite to what was seen on the left side M mode. So we've lost that seashore appearance. So the haziness that comes with lung sliding, we've lost that. And what you now see is this uniform stratosphere sign using this M mode. And this is just having them both. So on the right is actually the left lung, where you see with the lung sliding, you see the haziness. And on the left is the right lung, where you're not seeing that anymore as the stratosphere sign. And so we scanned a bit further, and this was difficult, and as Karim talked about earlier, about getting the lung point in. So this was quite challenging posteriorly to try and identify, but what we are seeing here on the right side is that lung point coming in quite low down. So that is a rule-in test to look for pneumothorax. And then this is a sort of magnified version where you're actually seeing that lung point coming into that side. Karim's going to show a better lung point, hopefully, a bit later on today. Oh, it is working. That's coming in quite nicely just there. This was his chest X-ray. As you can see, he's got a significant right-sided pneumothorax on that side. So that should correspond to the ultrasound findings that we saw. So the summary of pneumothorax and POCUS is, as we saw, absent lung sliding. There was no big lines visible. We saw the stratosphere sign on the M mode, and an absent lung pulse, which I forgot to talk about. But we did find a lung point which sort of broadened the pneumothorax, and that's the end.
Hello. Thank you very much. Can you tell us a little bit more about what your experience was with using the machine and doing the scan?
It was interesting, isn't it? So this was the first time I'd done a point-of-care ultrasound. I think I'd been on a course a couple of years ago, and actually just orientating myself to the probe, you know, putting in patient details, selecting the right views, and then actually just becoming familiar with holding the probe and positioning on the chest, using, you know, identifying the correct areas to be scanning, starting with the other side first. I think it is important that we are annotating and we are going back and looking at that. So I was very grateful for Karim helping out with that. It's interesting. We did another point-of-care ultrasound yesterday on a young chap and made a diagnosis, and he ended up in CCU. But actually, health guide management, initial management, clinical assessment on an X-ray that was, you know, could be this and could be that. And definitely I see its value, especially on AAU, when you actually want to just make a quick assessment to start off management, especially when the story is not typical. So this is quite helpful to do and just familiarize as a new starter with the machine. It's not scary, but I think it is just about becoming comfortable with the probe and the actual machine, which I think are important steps when you've not done it before.
Wonderful. Thank you. Thank you. I'm very, very grateful you came and presented, and we have lots more cases. Yes.
Great start to your career, because your first patient has a pneumothorax, which I've yet to see with ultrasound. I think it's an amazing hit rate, Mridula, for your as you're collecting your first cases that you've struck.
I download my logbook tonight.
Absolutely brilliant.
That's brilliant. Okay, I think we've got another case now. Yasir, are you here?
Yes, can you hear me?
Yes, we can hear you.
Okay. Let me see how I can share the image. I'm very new to this sharing business.
Can I help, Yasir?
Yes.
So if you hover on the screen,
Yeah.
by your faces,
Yeah.
you should see a few things on the bottom on the bar of a camera, a mic, and the third button should be of share.
The third button should be the share.
With the rectangle with the arrow pointing up. So, have you found it?
Let me see.
And then you need to choose the screen you're going to share.
Yeah.
Okay, so that's the next point. Otherwise, they will only see your face.
Yeah, I can see the share. And then let me click on this. Can you guys see it? Hello?
Yes, I can
Yes,
see
sir.
it.
Okay, can you hear me clearly?
Yes.
Okay,
ahead.
perfect. So hello
Yeah.
everyone, my name is Yasir. I'm one of the A&E Clinical Fellows at Oxford. I'll be presenting a case today that has to do with the amazing lung ultrasound. So our case is, this case, I've seen it almost, that was a long time back, almost 5 or 6 years back. And I tried to bring this case on board because I just wanted to highlight that lung ultrasound and thoracic ultrasound has been there for a while. It's not only with COVID, we're not only scanning COVID, we're doing ultrasound for variety of diagnoses, and this is just a case study to highlight that. So I was in the emergency department, I was working in an evening shift, and I've seen this 36-year-old male who presented after jet ski injury. He went to another hospital who said everything is fine, and then came to our hospital complaining of mild chest pain and shortness of breath. His blood pressure was normal, heart rate was normal, statin fine, RR21 and temp of 37.1. We did a primary survey, there was no life or limb-threatening injuries. And then there was positive tenderness on the right, 4th and 5th ribs around the anterior axillary line. There was, however, no subcutaneous emphysema. There was a normal examination otherwise. And at that point in time, which was 5 years back, everyone was used to fast exams, not necessarily e-fast. So we did the fast exam, which was negative. And then because of this chest pain that he was having, we ordered a chest x-ray. And for everyone to know, this is a PA view of the chest x-ray. So this is not a supine view. This was not someone who was laying in erect. No, this was a departmental x-ray. And as you can see here, I don't know if anyone wants to comment, but we did not see any abnormality with the x-ray. And actually, we used to have a system where some x-rays used to be reported, like nowadays with COVID, some x-rays you see reported as typical COVID, not typical, or even not reported. But this x-ray was actually reported, and this was pre-COVID time and everything. It was reported as normal, with clear lung fields and normal mediastinal contour. However, the patient, I was not happy with that. The RR of 21, the tenderness, and I remember Dr. Vicky, one of the lung ultrasound gurus that got me introduced to eFast. So I thought, why not just scan this patient? He's a perfect candidate. Let us grab the linear probe to do a scan. So that's what I did next. What you do next with a normal X-ray is grab the probe. Now, as you can see here, I just want to confirm, is my sound clear for everyone?
Yes, it is clear.
Perfect. So we divide the lung to 6 zones for lung ultrasound, 2 anterior, 2 lateral, and 2 posterior, and that's 6 zones each hemithorax. So R1 is the upper anterior one, had very nice lung sliding, pleural sliding, and shimmering that you can see there. R2, which is the anterior inferior segment, that is the lung, that's the pleural line there, which is very different from this nice shimmering that you see with the sliding pleural. And then I got worried. I was like, why is this patient having absent lung sliding? He's healthy, he's young. And then I follow that by R3 and R4, and I'll just give you R4 findings. And what you can see here, and that was the first time that I see lung point. And this is basically what you're seeing on this scan. This point there, where there's sliding and there's absent sliding on the other side, is basically the lung point and is the start of a pneumothorax. So beyond this line is air and a pneumothorax. And then I was like, Yasir, are you really sure with what you have just imaged? This guy's x-ray is absolutely normal. What are you saying? So I was thinking myself, should I raise this further? What should I do? But because I was such a strong ultrasound advocate, I was not going to let this go and discharge or whatever with the normal x-ray. I wouldn't have been blamed or anything, but it wasn't good for the patient. And I really believed in ultrasound. And I went, and we only used to have fast, and not many people, only our ultrasound director used to teach us the eFast, the lung ultrasound, the DVTs and all that. But the consultant who was on in shift that time was not a POCUS practitioner. However, he did take my word for it that this is abnormal, and we ordered a CT scan. Because yet this was the first time that I see lung point live, me diagnosing it. I've seen it in videos and teaching, but never diagnosed. So we do a CT scan, and this guy has a moderate pneumothorax. And I was completely amazed. And I literally fell in love with ultrasound at that point. I was like, what the hell? What is X-ray is not showing any of that? And we detected it just by bedside ultrasound. And we used to have a small portable ultrasound at that time. We did not have the big sonocytes or the General Electric ones. No, we had a small ultrasound which you handhold and just do the ultrasound scan. And I obviously used the linear probe because it was it's high frequency. It gives you very clear images of the pleura when that's what you're concerned about. If you're concerned about pulmonary edema and hemothorax and all of that, then you need to use a curvilinear or phase array probe. But because I was just focused with the pneumothorax diagnosis on that patient and a pleural sliding, that's why I used, and it gave me very clear images of a lung point, which was confirmed by a CT scan. We went further and inserted a pectate for that patient, 12 French, small one, to drain the pneumothorax because he was breathless and complaining of chest pain, although he was saturating fine. And what I came to know later on, he ended up very well. That was removed in a few days, and then he was discharged. But what I'm going to show you here is a clip of a re-expanding lung. This is not of the patient that I saw, but this is a very nice clip to demonstrate how the pleura comes and the lung re-expansion happens post pectile insertion. So this is going to get repeated now. Basically, it will show there is no sliding here, and you will slowly see the pleura coming into place, sliding with the visceral pleura, and re-expansion of the lung happening in real time in ultrasound. So what's the sensitivity and specificity of ultrasound for detection of pneumothorax when performed by ED physicians after blunt trauma? So this is, I'll re-emphasize that this is by ED physicians. There's not a radiologist performed lung ultrasound. And the sensitivity of this ranges between 86 to 98.2% versus supine chest X-rays, which is a lot of times I see this, and I'm sure many of you have seen trauma patient coming in. We grab the X-ray, chest X-ray, pelvis X-ray, portable, and then we see, oh, X-ray is fine, pelvis is fine, then everyone is happy. But actually, you'll only be detecting 28 to a maximum of 75% with a supine AP chest X-ray, with an AP chest X-ray, with a supine erect. So comparing this sensitivity with this sensitivity is just crazy. It's I don't know what the value is of obtaining an AP chest X-ray for pneumothorax in trauma patients. If you're gonna get a chest X-ray, you better get a PA view of chest X-ray, which the sensitivity is around around 92% and over. But getting a supine, a portable chest X-ray for a trauma patient to rule out pneumothorax is close to useless. So if you want to do a chest X-ray, either do it departmental or grab the probe and scan this patient. So please keep these figures in mind. However, going on in my practice with ultrasound, I used to perform the blue protocol more often, and then I got introduced to because we see a lot of critically ill patients in the emergency department as well. So the question came up is, how sensitive is performing a lung ultrasound, thoracic ultrasound for pneumothorax in the non-trauma patients? So not in the trauma healthy people who are generally in their third or fourth decades. No, it's in the elderly, or it's people with comorbidities or people who are critically ill. And to answer that question, Lichtenstein provided very great articles and insight into ICU patients and how sensitive is absent lung sliding. So I'll just re-emphasize the point that it's absent lung sliding. It's not detection of a lung point. It's not detection of comet tail artifacts or Z lines or B lines or lung pulse. It's just the sole finding of absent lung sliding, because that's our first clue. If there is lung sliding, you've just ruled out pneumothorax in the segment that you have the probe on. But if you don't have lung sliding, that does not equate to pneumothorax, specifically in the non-trauma population. And you can see in his articles, he stated that the positive predictive value of abolished lung sliding for pneumothorax in the general population was around 87, which is very good. However, in the critically ill, it goes down to 56%. And in patients with risk failure, it goes down to 27%. So just be very careful equating absent pleural sliding to pneumothorax. And on that note, what are the causes of absent lung sliding besides pneumothorax? And this article was published by a pulmonary consultant who's also into ultrasound. You can have reduced air into lung from a right main stem intubation, from a mucus plug, from a tumor, from a pneumonectomy. You can have extensive pneumonia, which causes pleurodesis, so inflammatory pleurodesis, which basically the viscera and parietal pleura stick together because of inflammation or fibrosis, and you will not see any lung sliding. So just be careful not to label these patients as false positive pneumothoraces. So, and for that, there was an international evidence-based recommendations for point-of-care lung ultrasound that was published in Intensive Care Medicine Journal. And they proposed this algorithm to diagnose pneumothorax. And this is very useful when you're not seeing the young, healthy patients with no lung pathologies. If you're seeing someone who's elderly with COPD or previous pneumonias and lung fibrosis, you actually ideally need to be using this algorithm to diagnose pneumothorax. And it starts by lung sliding as always. And if there is, yes, there is lung sliding, you basically ruled out pneumothorax. However, it's on that segment, on the segment that you have the probe over, because you will find with practice and years coming on, scanning trauma patients and your EFAST is negative, and then you do a CT scan and there is a tiny pneumothorax at the fifth rib posteriorly, which is less than 1 centimeter, just a tiny bit of a pneumothorax. And some other times you'll find another pneumothorax, but just be careful. When you're saying no pneumothorax, it means that there is no pneumothorax in the area that you're scanning, not somewhere else that you're not scanning. So if you're scanning anteriorly and laterally, well, yes, there's no pneumothorax, but if you're not scanning posteriorly, you will find that over and over in your practice. So if there's lung sliding, yes, then there's no pneumothorax. If there's no lung sliding, then you need to go down the algorithm before labeling it as a pneumothorax. It starts with B lines and comet tail artifacts, and then it goes to lung point. If there's B lines, then you've ruled out pneumothorax. There's no B lines, you go to lung point. And if you found the lung point, obviously there's a pneumothorax. If you haven't found, check for a lung pulse. If you check for a lung pulse and there is a lung pulse, yes, it means you've ruled out the pneumothorax. However, if you found no lung sliding, no B lines, lung point, or a lung pulse, then you've conferred pneumothorax. And this is, I would say this is more ideal to be used in our critically ill patients, which are not only seen in ICU, but we see a fair amount in our emergency departments. So I've put this I'll explain this with these nice images, which was prepared by my previous program, ultrasound program director, Dr. Rasha Mohamed. And she was an ultrasound fellow in Michigan. So basically, she put this algorithm with these videos to illustrate what everything means. Is there lung sliding? Yes, there is, and you can see there is very good lung sliding. Then you have ruled out pneumothorax. If there is no lung sliding, you go on to see if there's no lung sliding, see if there's any B lines. Do you see these comet tail artifacts, these vertical reverberations, these vertical shadows emanating from the pleural line? These are called comet tail artifacts or Z lines. If there is any of these comet tail artifacts emanating from the pleura, it means there is no pneumothorax. Basically, the pleura are sliding nicely together. If you haven't seen these comet tail artifacts, then can you identify a lung point? And if you can, then obviously you've ruled in pneumothorax. If you can't see a lung point, what about a lung pulse? I know many may have not heard of a lung pulse. It's not an easy sign to see, but basically it's when the pleura are pulsating back and forth because of the mediastinum, the contractility of the heart. You will see this pleura sliding on top of each other with the pulse. It's not as clear as the normal lung sliding, it's more of a lung pulse. So if you see any of these findings, then there is no pneumothorax. However, if you haven't seen a lung sliding or comet tail artifacts or even a lung pulse, even if you haven't detected the lung point, then this is likely to be a pneumothorax. A pneumothorax would be a small one if you detect it anteriorly, to be much larger if you're detecting it laterally. However, this is just for quantification purposes. But I thought this image or this illustration quite useful. And then I'll just end up with few learning points here, that lung ultrasound is more sensitive, way more sensitive than a supine chest X-ray for detection of pneumothorax. And then identification of a lung point aids in the diagnosis of lung ultrasound with nearly 100% specificity. And always remember, when you're always in doubt, even if you have a PA view of a chest X-ray and you're in doubt, just grab the probe, scan the patient. There is no harm in scanning a patient, and you might actually, like in this case, find a positive diagnosis. And lastly, there might only be harm if you misinterpret the images and call false positives or false negatives without knowing the literature behind it. Thank you all, and hope this was useful for anyone.
That's great, Yasir. Thank you so much. That was very good introduction and good explanation on how to diagnose, rule in and rule out pneumothoraces. We've had some comments based on what you said during your presentation, which is your sentence of, "That was the moment I fell in love with ultrasound." And we've been having a chat in the background, and everyone's telling us what their moment was when they fell in love with ultrasound. Thanks for starting that conversation. We have, continuing with the theme of pneumothoraces, we've got Conrad, who's also got some exciting cases for us today. Conrad, are you there?
Yes, I'm here. Hold on.
Hi.
Let me share my screen quickly. Should be on.
Conrad, would you tell us a little bit about yourself?
I will do that.
Yeah.
My name is Conrad. I was born at a very young age. I'm just kidding. I'm an emergency physician in South Africa who's doing a POCUS, ICU and Echo Fellowship in Oxford, in the JR and sometimes in Churchill. So I'm very glad Yasir spoke before me, because my talk will probably go on with his, where he focused on the pleural and the pneumothorax, which is great. And I had two cases where it was really difficult to delineate that and to get the point across, what he got across amazingly. And I was what this talk should be about is like what can influence the sensitivity and specificity. That's human factors and physical factors, rather than just referring to the literature, because we don't know the context of which it was done in. And sometimes if you're doing an ultrasound in trauma or an ED, especially now in COVID era, it's not the same system it was before, and sometimes you're pushed to make decisions. So without further ado, I'm going to go on and saying there was two cases that I want to present, which was very interesting to me. I've fallen in love with ultrasound quite a while ago. I don't actually have a recollection moment, but the thing is, I keep falling in love with it.
Okay, that's good.
So the first case we had is
sorry, Conrad, to stop you. I think we need you to go back to your first slide, or
yeah. See it?
Yasir?
Yes.
Have you stopped screen share, please?
You
have.
I
Okay.
So.
You think so? Okay. Conrad, we can see your references slide, I think.
No. Then just wait a second. This is not.
Give it a try. I can still see his as well.
Yeah. Great. Okay. I think he's gone. Now you're ready, Conrad.
See if this
Great.
works.
You. We can see you.
Okay. Does this come up now?
I'm
pressing share. I'll press it again. It worked earlier.
You choose which of the bit that's perfect.
Yes.
Yes. We can see your slides now.
Okay. Like I said before, I'm super glad it was a very good presentation from Yasir and his pleural and approach to the pleural and pneumothoraces. So the two cases I'm going to speak about was where it was difficult to enforce your findings, and I completely agree with him about the supine view in trauma. Waiting for that X-ray to make a decision with or without unstable patient is really going to miss many. And this is some cases where ultrasound and the use of ultrasound was used, and how it was sometimes difficult, and what issues make it more difficult to get to the sensitivity and specificity we want to. So the first case, there's a case pre-COVID era, and I'm saying pre-COVID because the area where we saw the patients was in a trauma unit or in ED and JR, and they've got resus beds where it's usually prepared well for accepting a trauma patient. And the post-COVID would be, there were technical issues, because now with a new situation, smaller rooms, trying to get into a non-previously trauma-orientated place, what was the role of ultrasound with or without, and can you get X-rays in there? So the first case was a 44-year-old male. He was on a very high ladder, 2.5 meters, got a shock, and at the scene, he then had a decreased level of consciousness. So if he got a shock, somehow these safety measures didn't work, from high voltage, high joules, maybe high amperes going through him, then fell on the ground, high fall, and was intubated at the scene. So in the system in JR, ICU, and everyone got a pre-call. And as we were busy managing him, he was in front of us with a good intubated, ventilated, and he was sedated with ketamine and fentanyl, and we switched to propofol later. His concerns was he's had a really fried left hand, and even with the ventilator, when the guys came in from pre-hospital, they said his left lung was really not moving at all, and they couldn't hear it. So they were concerned about a pneumothorax from his fall, and they did do needle decompression. With evaluating him and having an ultrasound together, we decided to actually look at it, because the patient's on positive pressure ventilation, and we had to look if there's a pneumothorax or not. He didn't have cardiac arrest through it, and he came in with, and his oxygenation was very low, even with high driving pressures on your ventilator and high FO2. So the people that were with us said, let's do a thoracotomy on the left or do a finger thoracostomy, and then hopefully that improves. And I thought, well, given the fact that we've got ultrasound here, he's got low SATs, but he's not hemodynamically unstable. Let's look at what's going on rather than just pop it in. And so after all the talks we had, the pleural sliding was present. There was good sliding, and then we did some things. And there's an important point when you're in this stressful situation, that what influences our positive predictive value and our images. And one of the things that I've recently come across, which I've adapted a bit more, is the fact that we need to choose the right mode as well. Because when you're looking for lung ultrasound or lung artifacts or sliding artifacts, we actually don't want to look at good lungs, and we don't actually need a beautiful image. And I'm saying beautiful image in terms of the filters that the machine uses. So lung ultrasound and pleural sliding is based on the movement and movement artifacts. So once you choose the preset modes, and in JR they've got the Mindray TE7, which is quite a good machine. And if you choose, you can see each of the software sides you choose, there's a different image quality. And that image quality is influenced by filters and post-image processing. Now, those post-image processing can influence the pleural sliding and the vision you can. It's almost like slowing it down, where if you're really struggling in a situation and you change your software to, which the one I used in the end was lung, then it takes away all those filters. And for quite a while, Lichtenstein was also saying the filters and facilities that we use in the machines, and the current machines, they can make beautiful images if you need beautiful images. But when it comes to lung, and the Lucy uses there is lung ultrasound of the critical ill, we don't want beautiful images because they can influence it. We want quick movement and take the filters off. So in this patient, we took the filters
Conrad?
off. Yes.
Conrad, sorry to stop. I think your screen share is paused for some reason. We can only see the first slide.
Oh gosh, let's see what I can do. Oh, I was a few slides in. Okay, let's see. Can you see? What can you see now?
I can see the second one, yes.
Okay, so let's go to this one. And unfortunately then the add-ons that I was trying to add on could not be on. Let's try once more. Okay, what can you see now?
So yeah, now you're on the third one, but I think this is what you did for your first slide, but then it wasn't moving ahead.
Is it moving at all now?
No.
Okay, so I will do the small slide like people did.
Yeah,
and
that's okay.
When we did put the probe on this patient, we saw these, and it's supposed to come in. Instead of having the absence of pleural sliding, even with the needle decompression that was done, we picked up that there's a lot of B lines in between rib spaces. And the decision was made then to not put in do a finger thoracostomy or do a thoracotomy in terms of putting a tube in intercostal drain, because this patient had B lines. And like Yasir said before, B lines are comet artifacts, but not all comet artifacts are B lines. So when exam questions come up, there are certain characteristics that makes a B line a B line. And a B line, in terms of how many you get, is a form of which interstitial syndrome and how much extravascular lung water you have. So this patient had many B lines. I think we counted five in the anterior view whilst teaching him. So we said, wait, there's something else going on here, and we will not then put in the drains. And just to follow up, can you see the change in slides now?
Yes.
Okay, so Lichtenstein, and we all are just indebted to Lichtenstein. Almost everything he's done has influenced us, and he was a big pusher. And I think when everyone told him that you can't image lungs on ultrasound, he said, and I agree with him, you probably can't, but as soon as the lungs are wet or pathological, then you can do it. And that's exactly what's happening. So in these cases, the case I'm presenting, the patient had a lot of extravascular lung water. And while I couldn't get consent for the CT, he had one side, the left side of his lung was completely white out with no pneumothorax. So the thought was that the current went through his hand, through his body, and completely fried his left lung. And by using ultrasound and looking for all the rockets that he has in terms of B lines, how many, we decided not to do an intervention that would have had a negative impact in this patient, even though it was influencing his oxygenation ventilation. Further down the line, this patient actually just had improvement in his consolidation and his compliance on the ventilator. So again, if this is supposed to go on, he had a current injury to the lungs. His oxygenation ventilation concerns was big, but we didn't do a drain. And while people said supine chest X-ray might have picked it up, people were still pushing for a left-sided intercostal drain, given the fact that the sensitivity and specificity of a supine chest X-ray was mentioned. So long story short, in this case, by using lung ultrasound, his left side was completely bonkers and not a good lung for the poor guy, but it was due to a different pathology than the pneumothorax. And it was interesting because it's not part of the normal trauma ultrasounds. He was a unique case, and when you get the EFAST protocol, it's lung sliding, fluid in the pleural cavity, and there you go off. The second case was extremely interesting because it influenced many aspects of trauma, but I'm going to focus on the ultrasound aspects of her. The poor lady was 23 years old. It was in the beginning of COVID, and she got, I think she used substances, got into a motor road traffic collision, hit a lamppost, and then people at the bedside found her, not the bedside, sorry, at the roadside, bystanders found that she didn't have a pulse and started CPR. She had about 15 minutes before EMS crew could get there, and she had 15 minutes of downtime. Now, when they saw her post-suspected cardiac arrest, although it was pre-hospital done by bystanders, we're not so sure how much she had, they found her to be decreased level of consciousness, which they did her RSI and they intubated her. She had a pulse of about 60 to 70, and she had a systolic that kept staying under 80. So the thought is, since there was no external bleeding, they thought that she might have been bleeding into some of her cavities, maybe the pleura, maybe the peritoneum, maybe retroperitoneal, and there was femoral swelling, and they thought she also fractured her femur, which wasn't the case later. So this poor lady had, like, a good trauma protocol, low blood products, suspected bleeding, or low blood pressure, suspected bleeding, had packed red cells given, had FFP given. She was confused and continuously not oxygenating and ventilating well. So when we saw an ED, now this is a different ED situation from previously. This is the post-COVID era, smaller room, X-rays can't really get in there easily or well, and it's just the environment is also difficult now. Everyone is in level 2 PPE, so sound and communication is much poorer. Using of visuals is much poorer. So in her case, and I remember this clearly, with her being sedated, ventilated, her driving pressure was about 20 centimeters water, really needed big pressures to get oxygen and FO2 to actually have an effect in her, and a SAT stayed about 90. So one of my other colleagues, and I was actually doing an ED shift and not the ICU shift, said we should do bilateral finger thoracostomies or intercostal drains for her, because given the context of trauma, and we should do this. And the lung ultrasound in the end made the decision, and there are influences that makes your lung ultrasound good or bad. The sensitivities we speak about is influenced by human factors, environmental factors. So the one paper that I found is, might be in my reference to the end, not every time you do a scan, you are up to your best. So we are looking at which machines we're using. Have we got the transducer right? Have we got the settings right? Have we got the frame rate right, the line density, and which areas are we using? And where are we scanning? Now, in this case, people are pushing for a patient whose SATs can't go up above 90 with 100% oxygen, high PEEP, high pressures. And then they said, well, it's all from a pneumothorax, or we have to do the management of a possible pneumothorax. And again, in this case, we used lung ultrasound, both sides. She had good pleural sliding, and luckily Yasir did amazing images in a talk on that. And then we found all these B lines along her pleura on both sides. The decision in the end was not to do finger thoracostomies and not to do ICD, and we transported her, accepting that we're struggling to ventilate her, but we didn't do unnecessary pipes in her, to CT. And this poor lady found that to have a C-spine injury, she had a C3 or C4, C5 fracture dislocation bifacet, and she had neurogenic shock. There was no areas in her body that was bleeding, and her hypotension was from a high spinal injury. When we got the bloods back from all the resuscitation, her HP was, I think, 17 or 18, because all her stuff was explainable by her neck injury. In this case, we could probably discuss the the use of pre-hospital ultrasound, but after using ultrasound in her, the decision was made that she's got a lot of B lines, she's post-cardiac arrest, she's had a lot of blood product transfusion. We think that she's got one of the interstitial syndrome, and without a tube in the end, it turns out that she had what we call transfusion-associated cardiac overload, the TACO injuries, because her C-spine injury mimicked hemorrhagic shock, and the blood products were given. She actually had a transfusion overload, and she went into pulmonary edema, which caused her poor lung compliance and oxygenation. And by using ultrasound and going a bit further than the pleura is sliding, there's no pneumothorax, or pleura is sliding, what is causing this? We saw 2 cases in the ones I do where interstitial syndrome of the lungs was the cause for the poor oxygenation and ventilation. And by using ultrasound, traditionally, where people would have had finger thoracostomies or ICDs done, we took 2 interventions that would add to the morbidity of a patient out of the equation. So the learning points I had from these cases, and like Yasir said, he fell in love with stuff, and what the learning points would be. So once you get beyond the pleura, we have now imaging modalities, and if you learn about it, how can we differentiate between what's going on inside the lungs in terms of interstitial syndrome? Is the atelectasis with the lung pulse sign? Have you tubed in the wrong side using the lung pulse sign? Or is there consolidation with dynamic air bronchograms or other features you can do inside the lungs? And remember that when we discuss the ultrasound sensitivity, it might be loaded and reported because now you are not the only one doing the ultrasound. And that's when Lichtenstein's numbers and other numbers come on. I think during those studies, they've got one guy and your job is to do ultrasound. So you go in, see everyone else is taking care of the patient, and you go do the ultrasound. So it's important for us to recognize that we are not always going into a situation and the only thing you can do for that patient is lung ultrasound or ultrasound in context. So we have to think that once we commit to scanning in these situations, we need to say, right, it is time to take a 3, 4, 5 minute focus and not be distracted and actually look at all the things and not skip good quality imaging in terms of for the benefit of the patient, and making our sensitivity much higher than having a quick, oh, I can't really see, this is what's happening between the ribs, I'm not sure, where once you commit to scanning, if you use a scanning technique and say this is focusing, then we can take some of the sensitivity away or increase your sensitivity and specificity, and also have effort on the environmental and surrounding factors and the technical difficulties we have with ultrasound. So again, not all trauma ultrasounds are hemos or nemos, and there are other cases, and these are 2 very interesting cases I found, and where lung ultrasound helped our management and the management of this patient to save them from certain morbidities and interventions we would have given them.
Thank you, Conrad. Thank you. Those both of those cases were fantastic. Any comments from the people who were listening? They were really good cases. I got very good feedback for the cases, Conrad.
Can I ask a question? I know we've been on for a while, but Conrad, thanks for presenting. When you had the whole team in a very high stress situation, advocating for what sounds like a very reasonable course of action, given the history and the findings of putting in thoracostomies, when the ultrasound then showed something contrary to what you expect, how did you then communicate that to the rest of the team? Because often it's quite difficult to use one, just the ultrasound if it goes against everything else. Like how were you able to change the whole team's view of what to do, especially if there were people there that weren't ultrasound positive or POCUS positive?
It is very difficult because thanks for the question. In both cases, there were people pushing for tubes. And the one case I was trauma leader and I said, well, I'm very comfortable with my call and we are doing this. And luckily there was a mutual understanding, the fact that the images were reproducible and people could see it. And I wasn't doing it in one corner while everyone else was busy. And I could explain the situation, but I really was expecting way more feedback saying, sorry, you are not doing the right thing. Luckily it was, and I think if, in retrospect, if it was a bad image or bad call, I would probably have lost all credibility. And that's one of the challenges of making these decisions based on images that aren't saved well. I did save some of these images, luckily. And that comes to team dynamics. I don't think there's an amazing answer to this. You can be in a different situation where you've got an obstructive answer and people are going to push against what you're saying, and the whole team environment can become toxic in that stage. But luckily, I was privileged enough to work with colleagues that said, okay, we understand your thought process behind this and we agree with it and we're going to do it.
Great. I think we have another question. Yasir?
Yes, can you hear me?
Yes.
Yeah, well, amazing case when lung ultrasound changes management, because it's really an extension of our examination. It's an extension of our old stethoscopes by new, better probes. I think what that case highlights maybe is a lung contusion, where you can see B lines and focal C pattern in some areas. But I think incorporating EFAS or lung ultrasound into trauma management is just so important. Otherwise, like in your case, we would have went down the route of chest tubes and all the complications with the chest tubes, whether it be infection or bleeding and all of that. So I think this just highlights the importance of point-of-care ultrasound in emergency medicine. It's just something that is, when in the right hands, with knowing the limitations of the ultrasound, you can do much with it. You can do beyond what we're doing right now.
Yeah, I completely agree.
Great. That was great. Thank you all for joining us this evening. Thank you to all of the presenters and our POCUS teachers. If you would like to present a case or bring us some teaching material in POCUS and present at our next webinar, please get in touch. We would love to hear from you. Until next time, good evening. Have a great week.